Good afternoon, everyone. We are going to start the last session before the exercise part of the Congress. Take part, either if you are playing soccer or running. So this is going to be the last sedentary act that you are going to do today. We are here today, very excited with the opportunity to share with all of you this symposium, this workshop, actually, because it's going to be very interactive. When we like to share with you, as I was saying, some work that IFSO is doing to tackle stigma. Thank you very much, Ximena. So we had the premise to challenge weight stigma and uncovering needs and opportunities in bariatric care and beyond. So our goals for today's workshop are first to discuss strategies to raise awareness among the surgical communities about weight bias and stigma and its effect on patients' experiences and health outcomes. We also want to identify strategies for collaborations to incrementally maximize IFSO's reach and efficacy in bringing about meaningful change while reducing duplication of effort. And our last goal today is speak action among the IFSO global membership, so you, for innovation in education, communication, clinical practice, policy, and advocacy to reduce weight stigma. So this is our team that has been impulsing this task force, and from now on it's gonna be growing for further actions. So I am chairing this symposium today, but also with me as moderator is Maria Jose Leiva. She's a psychologist here from Chile, with long trajectory on treating people living with obesity. We have Dr. Ricardo Cohen, the IFSO president, well known for all of you, and who was really believing in this project and actually the core in launching all this strategy. And we are lucky having also Ximena Ramos-Salas. She is from the University of Lund, Sweden, and also she also runs Bias 180 and is also has some relationship with Obesity Canada and also with EASO. She is also leader in, tackling weight stigma and trying to identify the specific actions in different countries in order to all of us go together beyond that problems. And lastly, we have Brad Hussey. He is unfortunately not here in person, but he's running all the work with us. And he is also from Bias 180 from Canada, and he's going to be in video recorded at all, but as I was saying, he also is leading the whole project. So, this is the agenda. We are going to talk about all this, so we move on with our first speaker, and Ricardo Cohen, please come up. I know you are super busy this afternoon, so we are so happy you can share with us your thoughts, and we understand you have to leave after this. So thank you very much. And yes, if you can please add his presentation.
Thank you very much, Violeta. Thank you, Mayor, for being here. And I was very enthusiastic when Violeta proposed this Stigma Task Force. This is one of the major barriers for the treatment of obesity, and I'm happy to share here my thoughts about why stigma is a great barrier against all access to care in obesity. I have nothing to disclose regarding this presentation, and this is the tip of the iceberg. We are very smart. We have long-term weight loss with surgery. We know most of the mechanisms of action. We have new drugs that deliver excellent outcomes with safety. However, we're not treating anybody. Metabolic surgery has a very low penetrance. Pharmacotherapy is low. So if you look at the people living with obesity, and if you look at the alternative that we have today, safe and effective, we're really doing nothing. So we are here trying to discuss several different surgical techniques, combined strategies. However, in the real world, we're not doing a good job. What is below the tip of the iceberg? The main thing below the tip of the iceberg is misconceptions on causes and treatment options, safety, cost, and stigma. However, I have to stress and highlight that all those misconceptions, the stigmatization against the treatment options, against safety and cost, come from stigma. So stigma is the great base of this pyramid. First, obesity was defined so far as a risk to health. So if I come and tell you that we have a risk to health, and I don't know when this will impact my health, and what should I think? So probably it's prophylactic, preventive. Should I be treated? Should I take medicines? Should I undergo surgery? Because if it's to prevent the evolution of a disease, I can think, sit and wait. This is what is unconscious in our population of persons living with obesity and even healthcare providers. We need to understand that BMI buckets do not tell the story. They're useful to see who is in size, in corpulence, bigger than the other. And maybe in some BMIs, they can tell us something. But in general, it doesn't tell the distribution of excess adiposity, and mainly if this excess adiposity leads to any impact to health. And this is totally well, doctors do not want to treat AIDS. But in obesity, that's normalized. Oh, yes, we need to prevent. And we forget about the millions of people, or not say the billions of people on planet Earth that are suffering from a disease now. There are some misconceptions on the causes of obesity. Obesity is not just calories in and calories out. There's a lot of different patterns, pathophysiological, that we know that's most of the part is genetical. It's not overeating that causes obesity. It's obesity, the disease, that causes overeating. We have a lot of scientific blindness that leads to misconceptions, but this is totally based on stigma. We are wonderful. We have RCTs that prove that have better glycemic control when compared to the medical treatment. So surgery is great, medications is great. We have studies like the SOS trial with 24% of total body weight loss long term. However, we're treating nobody. There's a lot of misconceptions about safety. Look at this survey that we did. Thank you. Look at this survey that we did 2 years ago, where most of the patients believe that surgery is too risky, while bypass, for example, mortality is comparable to a knee arthroplasty. So we are 10 times safer than a cardiac surgery. So yes, we have a very safe option. However, we are stigmatized because obesity itself is stigmatized. There's a lot of misconceptions about cost. What do health insurance payers in general think? Do they care about long-term effectiveness? No. Quality of evidence? We have science? No. They think about return of investment. So wonder if a person have a cancer, a melanoma. I'm not totally against cancer, of course, they need treatment. But a drug for melanoma, for example, that increases 6 months of an individual life will be paid. However, medications and surgery will be declined. So what they care actually is the upfront costs and fearing of opening the floodgates. So if we're doing 1% of the eligible patients, if I open the floodgates 10 times, we'll be doing 10% of the eligible patients. So this is what they think. They don't care about us. They don't care about new guidelines. They don't care about anything because there is stigma holding evidence-based. I would replace MBS for treatments. So, and this is one of the guilts. Obesity is one of the only diseases where healthcare providers ask the treatment to treat them. You need to show that you're compliant, and then I will refer you to surgery. You'll be treated if you show you want it. Imagine this at the ophthalmology office. So you have myopia, and the ophthalmologist looks at you and says, you have to squeeze your eyes. If you squeeze your eyes perfectly 6 months, I'll prescribe you lenses. It's a joke, but this happens with obesity. We need a change. Is it easy? Not at all. First, adequate wording. It's mandatory to use people-first language. People live with obesity, suffer from obesity. Is a person cancerous? Do doctors at the outpatient clinic call, hey, the next cancerous patient? Never. But the next obese, the big guy, this will happen. So this is the first step. Second, eliminate the stigmatizing elements. This is in the OR. It's not in our hospital. Otherwise, I would burn this table. Obese. This is Portuguese. Obese. So imagine if in the same hospital where a colon cancer we operate in the room besides this, it will be called eidetic. Never. But obese, they can tag the table. So this is implicit. We need to have appropriate facilities, as we actually do. We need to be friendly, we need to be warm, and accommodate the needs of our patients. Huge doors, WCs, big aisles. The patients need to feel really treated in the environment they're looking for treatment, care. We need to show them that surgery is not the last resort. It's not at all. When well educated, it's the best option. Oh, we have tirzepatide. Okay, but if the patient is fit for surgery, it's not the last resort. It's the best for him or her. It's not the easy way. No, it's the best treatment when well educated. This is one of the missions of our anti-stigma task force. First, teach even my peer surgeons. I'm ashamed to say that, but some of them need education, that overeating does not cause obesity. It's obesity, the disease, that causes overeating. Obesity is not an eating disorder. Obesity is not a mental disease, an addiction, or a vice. Obesity is a primary metabolic illness with alterations in the function of tissues, organs, and the entire individual due to excessive and or abnormal adiposity. This is our one of the IFSO position statement published early this year. So we have several barriers to treat obesity. First, we need to acknowledge that obesity is a complex chronic disease. It must be recognized across the spectrum. We have different patients with different BMIs, with different limitations. We have people with a risk factor. We have people with disease now. So they need to be distinct strategies and approach. Second, this is urgent. We need to avoid diagnostic and therapeutic inertia because those persons need treatment. This should be destroyed. Weight bias and stigma should be eliminated. And it's a work in progress. However, it's hard because this is embedded in the person's mind for decades. We urge to have comprehensive and multimodal obesity care. So, for example, the IFSO changed its name. We amended the name of IFSO. Now we are the International Federation for the Surgery and Other Therapies for Obesity. So we need to treat everybody to whatever fits for him or for her. And finally, we need to make health systems to understand that we need an obesity care pathway to serve the most who need treatment and deliver the best evidence-based care to them. Thank you very much.
It's not? Okay, thank you. Thank you, Ricardo. So we know you have to leave. Thank you for being here, but I will, well, honestly, thank you very much for your leadership. I mean, leading this initiative at IFSO is very important, and your leadership is essential to create change. We know you did many, many things during this last year. You will continue doing more, we know, because we know you. But the fact that you are here and putting the effort and considering this is really humongous. So thank you very much for all you have been doing.
And count on me. Thank you.
Okay, so let's see exactly. Yes. So please, from the back, can we have Ximena's slides back so we can continue? So Ximena, yes, please come to the stage. And Ximena is gonna tell us about weight bias and stigma, and the implications for obesity care, patient experience, and the outcomes, and the healthcare policies. So Ximena.
Thank you so much, everyone, for coming here. It's so wonderful to see so many people here, and to see that for such a new task force that we are able to have so much engagement already. And that's the whole purpose of this initiative, to try to engage as many of you as possible in what IFSO does next. So my name is Ximena Ramos Salas. I live in Sweden. And first of all, I would like to explain what Bias 180 is. Bias 180 is a nonprofit global organization that is registered in Ontario, Canada. And we get our grants from unrestricted grants, government grants, et cetera, and foundations. And our goal is to really address chronic disease stigma. So we know that people living with chronic diseases around the world are increasing. People are living with multiple chronic diseases nowadays, and many of these chronic diseases do face stigmatization. People living with obesity often live with multiple stigmatized conditions, and we're going to talk a little bit about that. So we started our foundation, our organization, in 2023, and we have done a few activities since then. We're very young. Our organization has done some policy workshops here in Chile and in Spain, and we also organized the International Weight Bias Summit in collaboration with Concordia University last year, which was aimed at developing research priorities for weight bias and stigma. We've also collaborated with the University of Leeds to develop a policy network to address weight bias and stigma, and this year we've done several workshops and partnered on an international research project called WISE, which is aiming at measuring and assessing weight bias in women across the lifespan in Canada, UK, and Germany. So my presentation today is going to be focusing on weight bias and stigma, the implications for obesity care, patient experience outcomes, and healthcare policies. These are my disclosures. As I mentioned, I'm chair of Bias 180, and I have several grants from CIHR and SHRC in Canada, as well as consulting fees from all of these nonprofit organizations. So to begin, I'd like to explain a little bit about what Ricardo already mentioned in terms of the main barrier that we face to increase access to obesity care is weight bias, stigma, and discrimination. And when we talk about weight bias, we talk about our own individual negative beliefs about a person because of their weight. These attitudes can be implicit, meaning that we're not consciously aware that we have negative attitudes about weight, or they can be explicit, meaning that we openly and overtly have negative comments about people because of their weight. Then they can also be internalized, meaning that we take those negative attitudes and apply them to ourselves, which leads to self-devaluation, self-criticism, and impacts on our self-identity. Weight stigma, on the other hand, refers to those manifestations of those biased attitudes into stigmatizing practices and stereotypes about people living with obesity. And discrimination is when we act on our own personal beliefs that are negative, plus those social stereotypes about weight and people with overweight and obesity, and treat people with overweight in an unfair and unjust manner. This is called discrimination. Now, what is causing this bias what are some examples of this bias beliefs about weight and about people who have a higher weight? So this is a pretty old initiative. It was from the World Health Organization many, many years ago, where the idea is obesity is basically seen as mostly preventable, like Ricardo was saying. We're saying that obesity prevention is easy. You just have to follow simple rules, eat healthy, balance your calories, and control your weight. The idea is that this is an individual responsibility that we can prevent by just doing individual behavior changes. This is an example from the UK.
When? Actually, do you know what? I'm all right, thanks.
Cutting down your portion size helps you get to a healthier weight. Choose to live better.
So the examples of these stigmatizing practices don't only just come from the media and social media, but they also come from public health. This is a recent example of the World Health Organization in Europe, where they talk about, obesity treatment to prevent cancer, specifically colorectal cancer. And of course, nobody was thinking that they wanted to stigmatize people living with obesity here, but they didn't think critically about the use of this image in this public health campaign. In the US, we've had many examples of causing stigmatization to children living with obesity, as well as parents, blaming the parents for their children's weight and disease, causing them to use these negative black and white images to fearmonger parents and families, blaming parents basically for their kids' weight. This is an initiative from the Caribbean, where kids are then portrayed as overeating, gluttonous children who are just simply eating unhealthy food. This is an example of a very popular news setting that talks about our supersized kids, and it's not just about genetics, it says, and diet. It's about our kids' lifestyles, right? So it's simplifying obesity as a lifestyle healthcare condition. And in the bariatric surgery world, we have these before and after pictures that simplify obesity as a body size issue, where we see the before and after pictures, the use of celebrities to promote bariatric surgery that can also contribute to the weight bias and stigma that we experience. And here's an example of how some people stigmatize bariatric surgery, like Ricardo was saying. Here we have an image, and it says weight loss surgery. Again, calling it weight loss surgery is stigmatizing, because it is not about weight loss alone. Weight loss surgery is a big decision for several reasons. First, it requires a serious lifestyle change. Second, it can be difficult to recover from. And third, it's not cheap. So there's a lot of misconceptions that are being portrayed in this image about metabolic and bariatric surgery. And of course, this leads to a lot of messages about, if you have bariatric surgery, that should work for you. And if you have recurrent weight gain after metabolic bariatric surgery, it's because you did that to yourself. And that leads to people internalizing the fact that they failed the surgery or the treatment did not fail them, they failed the surgery. So all of these examples contribute to those stereotypes and are based on those stereotypes that people who have overweight and are experiencing obesity are lazy, unintelligent, lacking willpower, and not able to control their eating and exercise behaviors. Now, the prevalence of weight bias is quite high. We know that people living with obesity experience weight bias across the lifespan, from childhood to adolescence to adulthood. 27% of kids in this study reported being bullied because of their weight in schools. 71% of adolescents reported being teased because of their weight amongst their peers. 66% of adults in the healthcare system claim that they're being stigmatized because of their weight, and many different countries, including Australia, Canada, France, Germany, and UK, and USA. And then the last image is to show that 20 to 50% of the entire population, this is not the population with obesity, the general population, 20 to 50% of the general population has internalized weight bias and feels bad about their weight. Now, weight bias in the healthcare setting is very common. This is a systematic review with 41 studies from 1989 to 2020 showing and measuring explicit and implicit weight bias amongst healthcare providers. And it shows that healthcare providers have implicit and explicit bias attitudes towards people living with obesity, and that has an impact. The impact is that patients feel that healthcare providers don't listen to their health concerns, that they spend less time with them during the consultation. Patients perceive patronizing and disrespectful language from their healthcare providers, and it impacts the quality of healthcare that patients receive. In addition, they tend to avoid the healthcare system for fear of being blamed and shamed for their weight by their healthcare providers. And of course, they also avoid obesity treatments because obesity treatments are stigmatized and seen as the easy way out. Here's an example of one quote. I'm only going to read one quote. There is such a stigma there that is reinforced. But when I enter the healthcare system, the first place I expect to talk candidly about my issue, I hear blame. Well, you know, if you eat right and exercise, you'll lose weight. It's as simple as that. It's a simple thing. That's what I get. It's so simple. So these are the experience of people living with obesity in the healthcare system that contribute to the internalization of these stereotypes. And this is a weight bias internalization scale that we use in research. It's not a clinical tool. But these are the statements that people who have internalized weight bias accept as valid for themselves. I hate myself for my weight. I feel anxious about my weight because of what people might think of me. Whenever I think a lot about my weight, I feel depressed. I feel that I'm less valuable because of my weight, and I feel anxious about being in public because of my weight. So imagine the burden of feeling this level of anxiety and internalized weight bias when you're trying to access the healthcare system. Of course, we have a lot of evidence that this creates a vicious cycle of stigma and obesity. This is a review that we published on stigma amongst adolescents, children and adolescents, that show that when they experience weight-based bullying and increased stigma experiences, it affects their self-esteem. They have increased depressive disorders, impaired school performance, decreased social involvement, which also affects their behavior, increased risk of eating disorders, unhealthy weight control behaviors, which leads to more pediatric obesity. This is a summary of the evidence that we systematically analyzed in the Canadian Clinical Practice Guidelines for reducing weight bias and stigma in the healthcare setting, where you can see that we have decades of research showing that stigma impacts physical health, psychological health, healthcare delivery, and social outcomes. Stigma is an independent determinant of health beyond obesity or a person's BMI. And this is why we consider stigma a social determinant of health. And in the public health world, where the world that I work in, I'm not a clinician, I'm a public health professional, stigma is considered a social determinant of health because it increases independently of somebody's disease or weight, morbidity and mortality, psychological health, social outcomes, and healthcare delivery, which causes health and social inequalities for people living with obesity. So these wide misconceptions that Ricardo was talking about earlier, that obesity is merely a risk factor, a lifestyle risk factor, is coming from the diet culture that we have in our society, and is treating obesity as a lifestyle risk factor and as a diet issue rather than a chronic disease. Along with this neglect that Ricardo was talking about, and the persistent stigmatization that people experience everywhere in their lives, in their families, in the workforce, in schools, in healthcare settings, in media, everywhere they face the stigma wherever they go, and it undermines the access to fair treatment and increases health disparities for people living with obesity. So when we think about policy, if you consider how we conceptualize obesity as a lifestyle issue, as a behavioral issue, as an individual responsibility, you can think backwards and think about what are the policies that we're going to develop if we think that obesity is a lifestyle condition, it's a lifestyle risk factor. So this is Carol Backey, who does critical analysis of policies, and I use this as part of my critical analysis of Canadian public health policies for obesity. And we found that for every policy solution, the bottom line is that people think that obesity is a lifestyle issue that can be prevented. And this is a study that we did with global public health obesity prevention experts, where one expert said, we're in this loop with obesity prevention, where folks have gotten comfortable with tried and true interventions. They believe it as a matter of theology because it funds their careers. You have these community-based projects for which there has been copious funding over the years, but they don't want to be bothered with providing data about whether or not the approach actually worked to prevent obesity. We have tried to prevent obesity all over the world for decades, and no country has been able to prevent obesity through these interventions. So, in summary, the public perception that chronic diseases like obesity, like sleep apnea, like MASLD, are preventable mainly through individual health behaviors, plus the value that we have in our society that health should be an individual responsibility, leads to us framing obesity as a modifiable lifestyle behavior and an individual responsibility. And when we treat weight and obesity as a behavior and as an individual responsibility, it leads to therapeutic inertia, which is what Ricardo was talking about. And so the belief that we can shame people so that they can change their behavior and lose weight is a fundamental driver of weight bias and stigma, and leads to people thinking that this is their fault and leads them to avoid seeking obesity treatment. Now, there are many causes of weight bias and stigma, and here's a summary slide of predictors of weight bias and stigma, but fundamentally, as I mentioned, is the belief that obesity is caused by personal responsibility and personal behaviors. That's the main driver of weight bias. Then we have the sociodemographic factors and cultural factors, as well as interpersonal factors. You know, if you have experienced weight bias and stigma from a young age, it means that you have been exposed to this environment, and it's going to increase your negative attitudes and beliefs about weight. Social influences, social norms, the diet culture that I mentioned about, this is about body size, it's about perfecting your body, and body shape leads to that weight bias and stigma experiences as well as the exposure of weight bias that we get from everywhere in the healthcare system and institutional healthcare settings and workplace settings. So what we know is that some healthcare providers believe it's okay to shame people. They think it's okay to stigmatize people because that's going to help them change their behavior. The evidence is very 100% clear. When a person feels shame, it will not support behavior change. When a person feels that they're being ashamed because of their weight, and they feel embarrassed about their weight and their health behaviors, they're going to avoid health-promoting behaviors, and they're going to avoid healthcare-seeking behaviors. So the belief that we can control our own weight and shaming people because of their weight is not effective. It's actually increasing the risk for obesity and other stigmatized conditions. So the fundamental change that we need to change is that we need to understand that weight is not a behavior. Obesity is not a behavior. Obesity is not something that persons chooses to do. And 40 to 70% of our weight is actually genetic. So shaming doesn't motivate changing behavior, and it actually causes increased stress, which increases cortisol in our bodies and causes cognitive, physiological, and behavioral outcomes that actually increase the risk for obesity. Here's a slide summarizing about the impact of weight stigma in metabolic and bariatric surgery settings. We know that people who perceive weight stigma in healthcare settings have more depression, anxiety, stress, binge eating, and impaired dietary adherence. People who experience stigma directly from interpersonal attacks also have lower self-esteem, body image issues, and concerns even before and after bariatric surgery. Internalized stigma, the shame of our own body weight, and self-blame reduces self-esteem as well, but it also is the major mediator to mental health outcomes and poor mental health outcomes after bariatric surgery. And anticipation of stigma. Believing that you're going to be shamed for your weight is the main driver of delayed surgical treatments, increased risk-taking in terms of non-evidence-based obesity treatment, not telling your family and peers and friends that you're going to go and get metabolic bariatric surgery because they don't want to be shamed for it. So we need to change the obesity narrative, framing And we need to change all of that because the diet culture messages that we have in our society are actually contributing to that misinformation about weight, health, and obesity. The public health messages that we have about eat less and move more contribute to weight bias. Stigma is an independent determinant of health, so we need to address it in our public health strategies. And the focus has been to date to manage obesity through willpower instead of relying on science. So we need to understand obesity is not a personal failure. The brain resists weight loss, and our weight and obesity risk are genetic. And of course, like Ricardo mentioned, we have a new definition of obesity, and it's not a body size. Obesity is not about body size. Obesity is about impairments in health related to excess adiposity. Now, quickly, we have this is a systematic review about which weight bias interventions we can use to reduce weight bias in healthcare settings. This is a brilliant review. I highly recommend for you to read it. But a lot of the interventions that we've done to date have been focused on education. And the education is basically to change beliefs amongst healthcare professionals about obesity as a chronic disease, about the causes of obesity. We know that if we train healthcare providers on the complexity of obesity, we can reduce weight bias. So that's an effective approach. We can also have interventions that create empathy towards people living with obesity, and we can have more weight-inclusive interventions. So rather than focusing on the weight loss, we focus on improving health and well-being, and we treat everybody with respect regardless of their weight. And of course, there are some policy interventions in terms of human rights approaches. In Canada, we've done a lot of work trying to change the Human Rights Act to be able to cover weight and obesity as protected areas under the Human Rights Code. And then lastly, I want to leave you with this slide because I think it's going to be relevant to our discussion. This is the results of the International Weight Bias Summit in 2024 that we had in Montreal last year. And the purpose was to identify research priorities. Like, what is it? What research do we need in weight bias and stigma from now on? And so we need more research on the direct consequences of weight bias and stigma. This needs to be looking at psychological impacts, social impacts, as well as long-term effects of weight bias and stigma, and looking at variations across populations, genders, ethnicities, and cultures. Most of the research we have in weight bias and stigma is from Western countries. We need more research in Asia and Latin America, Africa, all over the world. We also need improved methodologies. Some of our methodologies are not being used consistently, and it's difficult to generalize the results. We need more clarity on the definitions that we use. A lot of people mix the definitions between bias, stigma, and discrimination, or they use them interchangeably. Diversity, again, we need to expand research beyond Western contexts. We need more intervention research. We need more evidence about what works to reduce weight bias and stigma. And we also need to do policy interventions. We need to understand what are the policy levers that we can use to reduce obesity discrimination. And of course, we need to translate all that research to actually create change. So I'm going to leave you with these last takeaway messages. Weight bias is everywhere. We can't ignore it anymore. What we say, how we say it, and the context in which we practice our healthcare practices or health promotion or chronic disease prevention, it really matters. So we need to check in with ourselves on our own attitudes and beliefs and reflect on how that impacts our behaviors and our interactions with people living with obesity. We need to avoid assumptions and misconceptions about weight and obesity and BMI and body size. We need to focus on applying person-centered healthcare and healthcare policies, and we need to use the right terminology. When we talk about obesity, we talk about clinical obesity and preclinical obesity. We don't talk about body size and BMI. And we need to critically assess all the health promotion initiatives that are talking about obesity prevention to make sure that we're not simplifying obesity as a lifestyle risk factor. And finally, we need to address weight stigma. We actually need to implement interventions to address stigma across society. So thank you for your attention. And now I'm going to introduce my colleague Brad Hussey, who sent a recorded presentation. It's very short, so if we can put Brad's presentation, that would be great.
¿Pueden
Hi,
darnos el
I'm Brad
video
Hussey.
de la
I'm a
presentación que
consultant
viene
who
a
spent the
continuación?
last 25 years working with nonprofits and other clients in chronic disease areas, including obesity. And I'm also on the board of directors for Bias 180, which Jimena has told you a little bit about. And today, as part of the IFSO Bias 180 Stigma Working Group, I'm hoping to give you a few things to think about as IFSO probes how to expand and amplify its role in bias and stigma through advocacy, communications, and education. So let's get into it. I have no real disclosures to note, but I have in the past, or I am now working with several global nonprofits in the obesity space. Many of these organizations do receive funding from government and industry and other sources. So weight bias and stigma have really been on the radar from a research perspective
¿Podrían
in
subir
one
un
way
poquito el
or
audio,
another
por
for
favor?
80 years, but certainly in the past 20 years, there's been increasing interest. And as more research and advocacy and education has been done around weight bias and stigma, we've seen it become a part of clinical practice guidelines over the past several years. Because we know, as Jimena told us earlier, that weight stigma on top of everything else worsens clinical outcomes. And all of this, of course, has entered the public discourse over the past several years. As media has started to pay attention to weight and obesity stigma, and patient voices have been elevated and amplified by NGOs around the world. And that's led to attempts to change law and policy at various levels with varying degrees of success so far. But we are starting to see some traction there, perhaps in some areas, as we've seen in New York City and other places. All of these successes have largely been driven by the ongoing work of global NGOs and other organizations and individuals who have really put the bias and stigma agenda at the forefront over the past 15 years or so. These are just a few of the NGOs who have made significant strides around the world. And they've done a lot of work in advocacy, education, and communication over the years. And it's been a rising tide that's kind of floated all boats. It's important to note that groups and individuals that are working to advance weight stigma and weight-based discrimination action come from different sectors and disciplines and worldviews, not just the obesity world. But the common aspect of their work is to reduce weight bias, stigma, and discrimination. And for example, there's action within the obesity scientific and advocacy community, as we know, but also the eating disorders community, the public health community, the education community, the mental health community, and so on. And the usual pathway to change, which of course is never this neat and tidy, is to take knowledge from research and patient experience and clinical perspectives down at the bottom of the slide and identify needs and gaps, to educate various audiences, inform stakeholders, and to advocate for progress, which is often in the form of systems changes and updates to legal frameworks and other policy areas. And there's no set recipe or roadmap for any of these three domains that will guarantee success. But in the 25 years or so that I've worked with NGOs and charities in healthcare and health sciences, I've noted some very common challenges to executing on all of these activities. And so communications challenges, I would say these are the top 5 things I've seen over and over again over the past several years. In terms of funding, it's often episodic. It's less than what best practices require. NGOs can have limited expertise depending on the size of the organization. Outside suppliers can be unfamiliar with obesity. And funding can often have strings attached to it, meaning the money comes for certain programs, but not necessarily the program that the NGO wants or needs to do. In terms of reach or measurement, incredibly important, but reach is really limited by things like the number and type of social media followers an organization may have, budgets, audience interest. Measurement can be incredibly expensive, especially when it comes to earned media measurement. It's also difficult to assess real impact. There's lots of noise out there. Many groups and individuals are communicating similar and opposing viewpoints, and there's trends in healthcare discourse that ebb and flow that may make your message not land in the way that you want it. And audience fatigue can be a big factor. Certain audiences are highly desired targets to reach, and they're just bombarded with messaging and outreach all day long. In terms of biases, obesity is obviously a highly stigmatized disease, and so communicating about weight bias and stigma to people who have bought into stigmatizing beliefs is especially difficult. Basically telling people that what they believe to be self-evident and common sense is not true is just not an easy sell. If it was as simple as explaining the science, we wouldn't have things like vaccine hesitancy or mistrust of new treatments. When it comes to education, very similar challenges with funding in terms of applicability and reach. Often education takes a one-size-fits-all But really what we ought to be doing is create education tailored to the specific needs of primary care audiences or allied health professionals or specialists. There are cultural and health systems differences that can require customization to really be effective. And really we need to be reaching people how they want to be reached with the right amount of detail and reaching them where they are. Shelf life is a huge issue. Research and practice and even social and political attitudes are constantly evolving, and so education must be nimble and keep pace, and it can be difficult to keep education updated. And again, there's these biases. Again, if I'm a healthcare professional with biased beliefs around obesity, it's going to be a challenge to get me to learn about obesity bias in the first place. And when it comes to advocacy, again, very similar challenges with funding. In terms of targets and timing, it can be really hard to reach influential decision makers. The NGO or charity cycles may not align with governments. And you may not be able to deliver a solution that policymakers can run with, or the solution may not be within their purview or their powers to execute. It's incredibly important to measure. It's also very difficult to measure impact here. And again, we have these deep-seated biases. If I'm a policymaker with biased beliefs around obesity, it's going to be a really big challenge to get me to be willing to learn about obesity bias and to do anything about it. So what's common to success across all three of these domains? I'd say in my experience, stop-start is not effective. Limitations in funding and resources, business and government cycles and trends mean that a lot of organizations are episodic in the way that they communicate and the way that they advocate and the way that they educate. And we know that sustained efforts across all three of these are key to success. Aligning needs, often programs aren't really tailored to what specific audiences need to learn and to help bring about change. So it can be hard to reach actual decision makers and give them what they need. In terms of strategy, success means doing what's necessary at the right time with the right tools, not just picking something to do like a social media campaign. Often we see groups doing the usual things because that's all the options that they have. But impact will only come with a sound strategy and sound execution of that strategy. And measurable goals, I can't stress this enough. If you can't measure it, how will you know it was the right thing to do or that it had any impact at all? So what can IFSO do? I would say just to remember that nothing effective is ever done off the side of someone's desk. And so I recommend that IFSO create a strategic plan for addressing weight bias and stigma. And that plan has to be sustainable. So it has to be a plan that survives turnover in staff and leadership and champion volunteers, that it's reliably and appropriately funded and a constant priority for IFSO. It has to be strategic. It has to be more than just talk, aim to affect change and work toward that change in practical steps. It has to be collaborative. There's many organizations, as I mentioned, working in this space. There's lots of experience and inspiration to mine out there, but it requires ongoing relationship building and trust building, and somebody has to do this on an ongoing basis. It has to be adaptable. It has to have value for all stakeholders, but you also have to be prepared to work in unique spaces with more narrow applicability. It has to be patient-informed. Can't stress this one enough. Patient voices are absolutely the key to changing hearts and minds about weight bias and stigma. And so many advocates out there are willing to share their stories. But this also needs to be managed, and patients need to be involved and feel supported throughout the process. And again, it has to be measurable. If you can't measure it, you'll never know that you're doing the right thing or that you're having any impact at all. And with that, I'll stop there. Thank you for your time. I look forward to the discussion, and I look forward to seeing where IFSO can go in terms of weight bias and stigma work.
Okay, let me introduce you now, Violeta Moise. Violeta is a clinical and research leader in nutrition, obesity, metabolic and bariatric surgery, and she is chair of the IFSO Integrated Health Executive Council and an international recognized speaker and author. ¿Qué pasó?
Okay, thank you very much. So let's continue. So we go to the most fun part, which is the interaction we are going to have after the presentation of the preliminary results of the work we started doing. So when we started planning all this initiative, we were considering to do this for activity, like having the global picture. And the first activity was assess IFSO members' needs in terms of resources and strategies to address weight bias and stigma. Also, we wanted to know about the gaps and priorities to develop further stigma initiatives. And for this, we started this process that led us to know, the preliminary results that I will gonna share now. But first, we started with the design of the product based on the existing research, and then we did a process of collaboration, testing the survey, and gather feedback from early users widely. So that's probably why you saw the advertisement of this big and open in social media stigma survey that many of you completed. Actually, we had a very nice response to this previous testing, and then it helps us to design and to evaluate and tailor more the questions we wanted to do in the final test. So now I am, as I said before, share with you the preliminary results of this questionnaire. But first, I want to introduce you in the second activity that we are starting right now with, considering all this information that we obtained from the first activity, which is to describe the patient's experiences with weight bias and stigma in the context of obesity and also metabolic and bariatric surgery. And this will inform the future patient-centered and interdisciplinary obesity care strategies that we are going to develop. And for that, this is going to be the process of this activity that is, as I was saying, in process right now. So we started, we will start in January next year with the design of the action, evaluating the importance and impact of this project. And about February, we will identify the actors, patients, people living with obesity, healthcare providers, and also we will consider some some leaders in the living labs, in this case of many institutions. We will start in Spain with a patient experience living labs that will help us to run all this process. So we have a process when we will do the planification of the strategy, and then we will perform some focus group, the analysis of these focus groups, and with all this information, we will be able to identify the unmet needs and the quotes that needs to be added in the patient survey. So this is going to be, for now, the actions that are going to be addressed specifically for people lived experiences. So going back to the results of our questionnaire. So when we sent, again, with the help of Manuela Mazzanera and Stephanie Darko, of course, they were very involved also in all the process, we directly sent the survey to delegates only, so we were avoiding to open it to social media because otherwise we could reach tailor IFSO delegates' needs. So in the end, we got like 130 answers. Almost 61% were men, and mostly from the European chapter, as you can see in these statistics in the map, in the world map, followed by the APC and the LAC. So you did very well, actually, answering the question to the people from Latin American chapter. Most of you are here, too. We also have a small number of responses from MENAC chapter and then from North American chapter. As you can see, the age of the responders was about variable, right? We had like a range of people between 35 and 44, and mostly were between 45 and 54 years old. And most of them were having more than 10 years of experience in the field of bariatric surgery and obesity. And you can see on the profession, well, they were mostly surgeons. So 100 of the 130 were surgeons. This is the 70% or a little more. And then registered dietitians were occupying the second place on the respondents. And there are then medical doctors, some registered nurse, psychologists and endocrinologists, and some physiotherapists that also responded to the questionnaire. So this already gave us a very important information, and is why integrated health people respond that less, that's just a few people from the integrated health responded. So we need to either reach better to get more answer, or just perhaps motivate our colleagues in engaging all these activities, thinking that it will contribute to change the scenario that we are having now. So regarding the healthcare setting, they were all of them almost working on a multidisciplinary team, which is also very nice information from IFSO. And most of them were either in public, private, or both. And we wanted, first of all, to learn about their beliefs. Because as Ximena was mentioning before, the beliefs are constructed based on our reality, and as we believe, we will act. And this is the triangle from the cognitive behavior therapy. This is all a circle that is well connected, and knowing the reality that we experience is based on our experience, is not the true reality, right? And this is well illustrated in this book, Liminal Thinking. I just encourage you to review it, because it's very helpful to help us to open new doors and understand that perhaps the obvious that we believe is the obvious is based on our beliefs. But look, the beliefs that we have are based on the attention, this little needle that we have in relation to our experience. But there is a huge range, which the authors call liminal space, that can hold our belief loosely and also our models loosely. So there is a huge room for change there. And that's why we were very interested in knowing about the beliefs of us, of the delegates of IFSO. So regarding how stigma and how healthcare providers treat people living with obesity, well, we asked these 3 questions that you see here. The first was, there is no stigma associated with metabolic and bariatric surgery, and well, almost 80% of people disagreed with that sentence. So they really believe that there is a stigma, right? But when we say, my peers tend to have negative attitudes toward people living with obesity, also about 75% of them consider, yes, they do. They mistreat them very badly. Actually, in the other questions, patients with obesity are frequent target of derogatory humor in medical settings. So again, these were 70% of them were agreed that this was the situation. So when we ask them about the patients undergoing obesity treatment who experience recurrent weight gain and the relation with the mistreat that they experience in the healthcare setting, again, you can see that most of them, more than 80%, consider that they are mistreated. So there is a situation when recurrent weight gain can be related also with this bad experience. And then we also wanted to know, how do healthcare providers feel about treating people living with obesity? And here you can see in these color bars when I feel frustrated with people with obesity. So there are, not that many amount of people that feel frustrated, but some are, as you can see, in less amount. But the good thing is that they also consider that people, even when they don't feel frustrated, they consider that people living with obesity can be difficult to deal with. Perhaps we need to talk more about this, because there are some specific considerations that could reverse the answer, but this is very interesting to know. And as we were saying before, the feelings are related to the cognition, to the thoughts we have, and that's related with the behavior. So this is an explanation that helps us understand why we act in certain way, and it's based on how we feel and what we believe, right? We also wanted to know the impact of stigma on health outcomes. For that, we consider this sentence about if stigma can impact short-term health outcomes, and 86% agreed on that, and also about long-term outcomes. In about 90% of people consider that stigma can affect also long-term outcomes. And then we also consider if that situation potentially will contribute to recurrent weight gain, feeling the stigma in the healthcare setting, and again, 77% agreed on that sentence. And also, we wanted to know if people living with obesity, so what was the healthcare providers' beliefs about people living with obesity, and if those who experience lack of willpower will experience more recurrent weight gain. So is recurrent weight gain related to less or lack of willpower? And well, most of them were agree on that. So you can see like about 60% of people consider this, 60% of healthcare providers, delegates from IFSO, and most of them surgeons consider that is related to lack of willpower. And well, this was very, very well evident in many, not only in research, but also in the scientific literature and the public papers, right? But lately, a lot of people was trying to identify the real reasons for what people can experience this recurrent weight gain. And actually, this was also seen in the next slide. But that I will come and I will back to that idea. But going back to recurrent weight gain, and if that will affect patients' willingness to return for follow-up care, consider additional obesity treatment option, of course, as we can imagine that was agreed for everyone. We know that but it's nice, right, that is now in numbers. The feeling that recurrent weight gain needs a better treatment and a better scenario to avoid this feeling that is drawn in this graph next to the graph that is done by a patient from UK actually. So and this is the point that I wanted to go back with. We wanted to link, okay, if it is not willpower, what is that is related with recurrent weight gain? So, well, here we asked them about the main causes of obesity and related to obesity that mainly caused by behavioral factors. And in this case, also 47% were agree on that. So some way they consider that are behavioral factors again, and this makes sense when they relate that with lack of willpower. But then when we ask them what is primarily responsible for recurrent weight gain, they do agreed on there are some metabolic and bariatric surgery that is associated with physiological situations and is not responsible 100% or primarily for the patient. So the patient is not 100% responsible for one side, by other side, they recognize there is lack of willpower, and by other side, behavior has a lot to do on it. So we were a little confused with these results, but well, we need to work more on education and activities to be able to put, all at the same place and be on the same page. So we wanted to know if surgeons think and reality in all the healthcare providers, not only surgeons, about who should focus on educating patients about the biological and psychological causes of recurrent weight gain. And well, we directly asked, do you think surgeons should be responsible? And 100% of them, not 100, but between between agree and completely agree, we had the majority of responses. So it's great that they consider themselves as a focus of education to their community or their patients. And regarding education, there is a lot to do on that in terms of education in programs in medical school and residency programs. As per this recent literature, you can see that there are just a few medicine schools that have these programs. So we have a lot of work to do on that sense, and it has to be done by all of us. So regarding patient self-stigma, so when we wanted to know about consider how healthcare providers considered and internalized stigma is an important factor for metabolic and bariatric surgery treatment outcomes. Well, most of them were agree or strongly agree on that, and also that it plays a significant role on long-term adherence to the programs. So also we acknowledge, and this is a nice result too, that cultural differences and stigma plays a role. So we need to advocate and target all the cultures and mitigate the bias that can be different in all of them, between them. And it was very interesting to know how stigma is associated with obesity reduces patient trust in healthcare professionals. This belief about the relationship between trust with professionals and adherence to treatments is well acknowledged for all the people that responded to the questionnaire. There was an 85% of them consider that we need to build on good bond with the patients, and this is actually mirroring the Picker's 8 principles of patient-centered care, where it's claiming for these kind of assumptions. And the last question that we wanted to share with you is that, well, when we give this sentence, I am aware of my own potential weight bias, the negative attitudes and beliefs I have with my patients, or stigmatizing practices towards people living with obesity, well, 60% of them disagreed on that. So perhaps there are a lot of contradictory results here, and this indicates that there is room for improvement. So of course, starting for questioning oneself is important to move on. And well, this is the mission we wanted to accomplish with this first activity. We wanted to understand the bigger picture that is after the stigma, and I think this is a great first step to move on. So I now encourage you all to participate in these 3 or 4 questions we have, and I thank you very much for your attention.
We invite you to stay a few minutes more at this session, because this part is really important for us. This is a workshop, so as we've been talking today at this session, reducing stigma is more than knowledge, and it's really important to have this space to be together now, rethinking about stigma. And it's really important to understand how stigma occurs and how it appears, but it's more important to questioning our beliefs. And this is what we are trying to do now with these questions that we're going to present to you.
So do we have the questions?
Yes. So you're going to have to need your cell phone. Either you go into the program where you have this session in your agenda, or we're going to put these Slido. You can use the QR code to get a few questions. And the idea of this question is both to feed our needs assessment, but also to engage in a discussion with you. Like, we want you to help us prioritize the activities that IFSO should do to address weight bias and stigma and discrimination within the IFSO community, but also beyond the IFSO community. So the first question. Yes. ¿Lo puedes decir en castellano? Sí.
La idea de las preguntas es que las respondamos a través del QR que está aquí y que luego podamos iniciar una conversación para que podamos pensar entre todos cuáles son las actividades o las formas en que debiésemos ir construyendo para poder ir introduciendo actividades, preguntas, espacios donde ir pensando y trabajando con cómo reducir el weight stigma en IFSO, pero eso es algo que tenemos que pensar entre todos. Y a partir de este momento pueden hacer las preguntas y pueden participar también en español si les queda más cómodo.
Creo que los resultados aparecen live. The results will show up live, I think. So the first question, in your view, which area should be prioritized first to reduce weight bias in bariatric healthcare settings? You can select the top 3 that you think are important to you.
¿Todos pudieron usar la aplicación? ¿Alguien tiene? ¿Sí? ¿Está todo andando? Ok.
Did everybody vote? No, that's okay. Take your time. Paciencia. Y por mientras, si alguien tiene preguntas, si quiere contribuir, if you want to contribute. Yeah, if you didn't understand something, if you want to bring your ideas or what IFSO should do, if it's not listed here, just, yeah, please, can you give him the microphone? And I will write it down.
Thank you. First of all, congratulations for the session. Actually, this is a very important issue. I had the opportunity to work in coverage of the bariatric surgery in Chile. And the biggest barrier to get a good policy for getting the coverage of the surgery was the stigma.
Yes.
Definitely. All of the authorities we talked to, mainly the health authorities, had a lot of stigma. But are they going to have their vitamins? Did they do their workout before surgery? What kind of persons, or even worse, stigma over the health professionals that are working on these patients? The surgeons, are they going to do surgery on obese patients, or they are going to do this as an aesthetic surgery? That was in the Congress. And patients that get the surgery, they also have another problems in some scenarios. We have, in particular, one patient that belongs to a family of obese patients. There were 5 members in his family. All of them suffered obesity. And she was the only one who could access to the surgery. 6 months later, she was discriminated by its own family because she was the only thin patient. So stigma, it's a huge issue in failure or even in success of the surgery. Congratulations and thank you for the session. Okay.
I have a question for you. So I think this is, exactly why we're doing this workshop, because what you identified is that there's a public, amongst policymakers, there's misunderstanding about obesity.
Absolutely.
And misconceptions. So do
Yes.
you think that policymakers should be a key target for interventions by IFSO?
Definitely.
Right.
Health providers, health insurance, and politics.
Yes, health
Definitely.
insurance, politicians, policymakers,
Yes, authorities.
authorities,
Yes.
even public health, I would argue.
Yeah.
Public health people who are
Definitely.
saying that we just need to prevent obesity.
Absolutely.
What about for the patient side? How do you think IFSO should address the patient stigma, like the experience that patients experience from their families, their peers, their, like, do you think IFSO has a role in that?
Absolutely.
Yes.
You help us making the guidelines for treatment of obesity,
Right.
And those guidelines are made not only for professionals, are made for patients. IFSO has to do their work also with patients, not only with professionals.
Learn about empowerment and to know their rights when they go facing healthcare providers. Definitely, that's education too.
Dr. Cohen is back. Come and join us.
Yeah, please go.
We have
go
lots
to the
of
stage.
questions for you.
Ricardo, please go there. No. You can stop. You cannot stop. Don't stop me now.
Yeah, first of all, yeah. Sí, of course. Yeah, my name is Aileen Wakeham. I am a psychologist and I work for 3 different teams in the south of Chile, which is a special kind of patient, people that maybe live in the countryside, and I work with some patients from Santiago, very urban, all different social strategies, no? And also our patients from Peru. And 2 things. The first of all, these answers that you gave to us, if you see the first 3 have more points because we cannot answer, we cannot choose all of them. But I'm pretty sure that all of them are as important, don't you think? Did it happen to you? No, you try to put all of them, no? So you can actually answer yes to all of these needs. And something that is worrying me a lot lately is that that now we have a strong movement of ¿cómo se llama? A positive body image, no? And there's a lot of influencers, no, talking about being overweight is okay, and they are talking about us as the mean guys. Yeah, I have a lovely friend of mine. She's 150 kilos overweight, and she actively posts and influences people saying that all of us in bariatric surgery and bariatric psychologists, we are mean people, we are killers, we are the main stigmatizing people, no? See, so what can you say to us? Because sometimes I engage in passionate discussion with her, no? But I was overweight heavily. I got surgery, no? So I understand that, but how can we help people go to the other side and understand that we are not stigmatizing people with overweight and that we don't want them to be skinny, no? Because they feel like that.
You have something to say? What? Yeah, Ricardo?
It depends on the way we address the issue. The first thing that we do is to show them that they have a disease at the moment, and all the and all the, when you address persons with obesity, you explain to them that all the strategies that we are proposing, surgery or medicines, because we see every day in social media that semaglutide is a cause of pancreatitis, blindness, amputations. We read all over the things, and the same with surgery, or worse with surgery. So we explain that we are the key opinion leaders to our patients. So we explain them that no, they're safe. All that the social media should be screened before being interpreted. And medications, for the pancreatitis example is the best one. They claim that pancreatitis increases with the medication. If you look at all the trials, including real-world data, not only randomized controlled trials, is lower than the average of in people living with obesity. Surgery, mortality of surgery is as low as a cholecystectomy. It's lower than a knee arthroplasty. So if you show them that obesity is a disease, you remove the guilty over their shoulder. This takes time, and this takes time. It's not in a 15 minutes consultation. You'll spend an hour with the patient, and I can tell you that 90% of the patients that come with this prejudice against themselves, they leave the office crying and saying, it's the first time I heard that it's not my fault. It's the first time I heard that the interventions will do good and not bad. So it's our job to do this.
So do you think that IFSO has a role in that patient education piece?
And yeah, and we're doing this actually. We have a direct-to-consumer campaign where it's 3 pillars. One of them is information about safety. The second one is a strategy that works with surgery. And the third one is anti-stigma. Yes. So we're doing this. And we're going to amplify this now, investing a little bit more in advertising the posts to which one of the anti-stigma posts had 2.4 million views. Wow. So it's important. And we invested a small amount of money, $400. Wow. And it was good. So it's an ongoing work. Yeah. People live in experience. Violeta, you spoke about stigma.
Yes.
I spoke about stigma. Yeah. Patients spoke about this. You should follow IFSO. Yeah.
So we're gonna go to the next question, and we're gonna get this data for IFSO later. So can we put the second question on this Slido poll? There we go. How confident are you that your organization, your clinic where you work, can effectively address weight stigma in bariatric practice today? How are you confident? ¿Cómo en español? No sé, ¿lo puedes traducir?
Sí, sí. ¿Te sientes confiado en que la organización en la que tú trabajas actualmente puede efectivamente hacerse cargo de reducir el weight stigma en la práctica que realizan hoy día con pacientes bariátricos?
And the point of this question is that we want to know how IFSO can support you to become more confident to address weight bias and stigma and discrimination in your bariatric healthcare setting. So it's not that we are trying to show that you're not confident, it's just that we need to know if IFSO should prioritize giving you resources, education, skills, capacity to be able to address weight bias and stigma.
Es una pregunta que tiene que ver con el equipo, no
Con
con
el
ellos.
equipo, con el equipo y con, yes.
Porque es distinto.
Yes. We're talking about your team, like your work team, your clinic team. Yeah. Okay, so people are answering. Any more questions? While people vote, feel free to add anything. Did we miss something? So what we heard is that you probably would have selected all the options in the first question, but you couldn't. But we need to prioritize because IFSO cannot do everything.
No.
So,
but we can do a lot.
We do a lot.
Yeah, we can do a lot.
The first one could be to prioritize, not to
we
choose
need to
one.
prioritize.
No, in the question.
Yeah,
So
yeah.
put it in order.
Yeah,
Which first?
yeah, we could do that.
Yeah, eso es lo que decía.
But I don't know if we can change it now.
No.
Yeah, no. Okay, so, how are we doing?
¿Todos correspondieron? ¿Todos pudieron responder la número 2?
Okay, so the answers are 39% moderately confident, 43%. Okay, so a few people in the bottom here, perfect. So let's go to the last question. One more, this is long. Which of the following barriers most hinders the progress towards equitable obesity care? So again, we said 3 but I know you want to pick all of them, but what are the top 3 that you think we could start with? Yes, there we go.
Esta pregunta tiene relación con entendiendo que pueden ser todos los puntos relevantes. ¿Cuáles son los que ustedes dirían que son los 3 más importantes?
We have 100%. We all agree. That's very interesting.
100% consensus.
It's amazing. This is the fastest. Oh, this is the fastest Delphis? No. Okay.
Okay. Oh, good, good.
No podemos concluir nada todavía.
No, we still have the policies.
Yeah, we need Ricardo going to the politics.
We need to support IFSO members to help develop national plans for obesity in their countries.
Look how media, yeah. So now C is in second place. Still voting, right? Mhm. What? Sí. Okay. Yeah. Ricardo, comment.
Yeah. Actually, we'll comment about what the poll, the policy changes. No.
Yeah, I wanted to see what IFSO can do for B. Point B.
What we can do is, as we were discussing here, a toolkit for all the national societies to guide them how to approach policymakers, private and public. Remember that the only disease that the healthcare providers want government is obesity. Nobody wants the government to say that tuberculosis is a disease.
No.
But obesity, people want, I cannot understand why. So if we have a toolkit to work with private payers, I wouldn't go to the government first, but unless the system is very good. Because if you go to the NHS, they provide tirzepatide if a person have a BMI over 45 and 4 associated diseases. So this, nobody will have access. So maybe I wouldn't go to a system like the NHS. But for private payers in different countries, we can, think on a strategy of straightforward toolkit. This is the pathway you have to follow to convince payers.
And then what would you do about the low awareness about obesity as a chronic disease? What can IFSO do? Pressure.
It's education, 5-minute CPDs, webinars, sessions like in this Congress. So this is the way to go. So it's education, and repetition is the key for learning.
So should we ask them what they think?
We are aware that we need to include more patients in our congresses. We keep saying that, and we will start with initiatives to really integrate our people lived experience in the meetings, because in this case, we are running out of time, very out of time. Okay, so any final comment from you?
Perdón, ¿lo puedo decir en español? Sí. Hola. Bueno, no es una pregunta, es más bien un comentario donde dicen educación, pero yo creo que este tipo de temas, creo que lo deberíamos de dar en la sala grande. Eso es lo que yo creo, ¿no?
Thank you. Final remark. I don't know if we need anything else. No? Oh,
I think everybody understood that.
Claudia there.
Did everybody understand what she said? She wants IFSO in the future to put the stigma topic in the big plenary room, so everybody can hear it.
Claudia Angarita de Colombia. Acabo de mandar una pregunta y es cómo educar a los cirujanos bariátricos en que sus redes no utilizan el estigma, porque normalmente utilizan el antes, el después, el cambio está en tus manos, el futuro lo tienes tú. Y pues al final dije eso, pues este simposio que es tan interesante, ¿cuántos médicos cirujanos hay acá? Doctor Cuenca, felicitaciones. 4. Muy bien, pero creo que falta eso realmente, porque para vender, para traer pacientes, utilizan ese método de mercadeo.
Needs more surgeons integrated.
Hindi. Sí.
¿Ok? ¿No? Voy a responder en español para poder explayarme en la respuesta.
Yo voy a traducir.
Ok. Me parece una muy buena pregunta porque apunta a lo que hemos dicho a lo largo de la sesión de hoy. El weight stigma podemos entenderlo o pareciera que hay una conversación que gira en torno a entender lo que es el weight stigma. Y sí, es verdad que hay que entender, que hay que leer, que necesitamos saber qué es este concepto. Pero luego, y eso es como un poco respondiendo a tu pregunta, probablemente muchos de ellos sí saben de qué se trata, pero incorporarlo y poder cambiar mis creencias y poder como asimilarlo en cómo yo entiendo y me relaciono con el mundo, como incorporándolo en mi manera de mirar, eso es un proceso que requiere de pasar y volver a pasar y volver a pasar por el mismo lugar hasta que nuestras creencias se van transformando. Entonces tenemos que ser pacientes, pero repetir esto que es en lo que estamos es parte de eso, de a lo que aludes.
So I think the question was about how do we address the bias that patients continually, no? The surgeons continue. Somebody translate.
No, why they still use images like
the before and after.
Before, yeah.
Yes, how do we get surgeons to stop the before and after?
They don't understand.
Okay, you can answer that. The mic?
Todos queremos hablar.
And then
In English or Spanish, whatever.
Nos están echando, nos pagaron la luz.
Es verdad.
We gotta go.
Yeah.
Como puedas, como quieras.
Spanish. Honestamente, hoy los cirujanos están mirando un declinio de volumen. No esperen que los cirujanos cambien ahora. Pero si nosotros tenemos menos estigma contra la obesidad, ellos y yo no me incluyo entre ellos, no miran que trayendo al paciente para cerca aumentan su volumen. Entonces, Andrea no está aquí, pero yo sugiero que Andrea del Program Committee sugiera una sesión después, y yo voy a influenciar también el programa, es fácil. Pero Andrea tiene que ser proactiva. La sugerencia de la sesión plenaria, que sea 1 hora. Pero yo llamaría totalmente diferente. Si pongas el tema, how you can increase your surgical volumes.
No ponga la palabra estigma. No ponga la palabra estigma.
No, remove the word stigma. How you can increase. Exactly. And you put on a panel, un panel de expertos que dicen, esto se hace para tratar más enfermos. Cambia.
A todos los tenemos de nuestro lado.
Okay.
I'm
just going to translate what he says, and then we got to go. He says we should include a session on stigma for all the surgeons at the conference next time, but we shouldn't call it stigma. We should say, how can you increase more patients into your bariatric surgery? And then we talk about stigma. Once we attract them there, we hook them, and then we...